So good afternoon, good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the first multiple sclerosis virtual clinic, our one-of-a-kind learning experience. During this educational activity, our top-notch MS experts will share with you real-world clinical cases. Therefore, I would like to invite you to interactively participate by analyzing the cases shared and by voting to the poll, as your participation will definitely make it a fruitful meeting. During our virtual clinic today, we will discuss sequencing of disease-modifying therapies for the treatment of multiple sclerosis. In the past decade, several DMTs have become available, from small molecules to monoclonal antibodies, for the treatment of mild to moderate or moderate to high disease activity in the relapsing form of MS. And due to the chronic nature of the disease, patients require long-term treatment, and suboptimal treatment response is a common concern with disease-modifying therapies. Optimization of therapy is therefore a growing challenge for neurologists who must evaluate the efficacy and safety of DMT, as well as individual preferences, adherence, and characteristics. Inappropriate dosing and the timing of treatment escalation can lead to suboptimal clinical response. Taken together, these factors contribute to therapeutic inertia, which may lead to failure of achieving treatment goals, worsening of clinical outcomes, and disability. Therefore, sequencing to high efficacy DMTs early in the disease course may improve the long-term prognosis. Before starting, let me thank Novartis for sponsoring this educational activity. In our first session, Professor Celia Oreja Guevara will discuss the landscape of existing therapy with the key factor for planning optimal DMT sequencing. Professor Celia is Vice Chair of Neurology at the University Hospital San Carlos and Professor of Neurology at the University Complutense Madrid, Spain. And after gaining her medical degree from the University of Madrid, Professor Oreja Guevara completed her PhD thesis in neuroimmunology at the Max Planck Institute of Neurobiology, Munich, Germany. She then completed a residency in the Department of Neurology at the University of Bochum, Germany, followed by a one-year fellowship in neuroimaging at the University Hospital San Raffaele, Milan, Italy. Since then, Professor Celia has held several posts, including Senior Neurology at the University of Düsseldorf, Germany, Head of Neurology Hospital de Fuenlabrada, and Chair of the Multiple Sclerosis Center at University Hospital La Paz, both in Madrid, Spain. Professor Celia's main interest of research are clinical and neuroimaging correlation in MS, family planning, the use of optimal coherence tomography, OCT, symptomatic therapy, neuromyelitis optica, and the evaluation of new drugs for the treatment of MS and MMO. She is currently co-chair of the Multiple Sclerosis Panel of the European Academy of Neurology and also a member of the Education Committee of the EAN, European Neurology Conference, and serves as an expert for the Scientific Advisory Group on Neurology of the European Medicine Agency. In addition, Professor Guevara has held leadership positions in a number of national organizations and academic societies, including the Demyelinating Disease Group and the Neuroimaging Group of the Spanish Neurological Society. She has also participated as a principal investigator in several MS and NMO clinical trials. Professor Celia, we are honored to have you as a speaker with us tonight. Welcome, and the floor is yours.
Thank you very much, Maya. Thank you very much to all the team and Novartis for inviting me to have this first virtual clinical event. I am very glad to do this. I know many of the people always in the Arabic countries, and it's always a pleasure to go there for talks, to meet friends. So I will, first of all, I will speak about the sequencing treatments therapies, and later I will show you two clinical cases, two easy clinical cases. So I will now share my screen. So you see my screen?
Yes, yes,
Perfect.
Professor.
Perfect. So the title of my presentation is "What do you need to know about sequencing DMTs?" And we will see what I can show you. So one thing that I want to show you and to remark is that MS is, as you know, a very long disease. It's a lifelong disease, and that is very heterogeneous. And that is important, that is a chronic disease and very long, because it means that when we are treating the patients with one treatment, we cannot only think about the first treatment, we need to think about all the sequencings, because perhaps when we are using one treatment, later we cannot use another treatments, or perhaps the side effects of this treatment are later implicated in the next treatment. So that is really very important how to choose the treatment, because the MS is a chronic disease and we need to use many different treatments in the life of the patient. So that really we need to choose very carefully our treatment. So that one point is because it's a chronic disease, we need to think really about not about the first treatment, so about how will we do the sequencing of all the treatments. So, and as very clear as you see here, but very clear, we start the treatments always as soon as possible when we have the diagnosis, and when we have exclude other diseases, and we always recommend to do magnetic resonance and CSF to avoid misdiagnosis. You know that in other countries, like in USA, they don't do CSF, and later they have more misdiagnosis, and that is important because some of the treatments are really very strong, and you cannot give a treatment a patient that has no MS. And that is the most important thing. What we are looking for is to prevent long-term disability. We want that our patients can stay many, many years working and working and having family, so that we try to preserve the brain. That is the most important thing. So that here is a very, very, very famous slide that is important, because you see here that you need to treat the patients very early, just at the beginning of the disease. Because when you treat the patients at the beginning of the disease, you have the patients with less disability, with less relapses, and with less inflammatory lesions in the MRI. So that is really very important to treat the patients from the beginning. Yeah, and when you treat the patients from the beginning, you are preserving the brain, and it's very similar like in the stroke. In the stroke, they say always time is brain, and should be the same for MS. Yeah, for MS, we cannot lose the time waiting for another relapse or waiting for more lesions. I think we need to always to change the patients when we think that they are necessary. And as Maya said before, it's very important because sometimes we have this therapeutic inertia and we don't switch the patients, and later the patients are worsening. So that is really very important. Time is brain, not only for the stroke, it's also for the multiple sclerosis. And when we want to choose a treatment, we always need to do a balance. Yeah, we only first the balance is we need to balance between efficacy of the treatment and safety of the treatment, and the risk not to treat the patients with the adequate treatment. So because many times we are thinking, yeah, we have a treatment that is very efficacious, has a lot of side effects, and we don't want to use because we think it has a lot of side effects. But when we don't use this treatment, perhaps the patient will be worse and worse and more. So that you always need to take into consideration not only the efficacy and safety of the product, the risk of not to treat in a adequate way the disease. So that is very important, the risk of the worsening of the disease. And here is, as Maya said before, it's always difficult to choose the treatment, and we need to take in consideration many different things. So, and I will start first with the preferences of the patient. So because normally the decision of the treatment should be always from physician and patient. And the patients, they have different preferences than physicians. And as you see here, the patients, when they want to choose a treatment, they have other things. They think about family planning. They think of route of administration. That is very important because You can perhaps you want that the patients, they can have an IV, but the patients later, they don't want to come to the hospital or things like that. Or you want to have an oral for the patient and later the patients forget the treatment. So that is very important. The route of administration, very important dosing and frequencies, and patients, when they need to take a lot of pills, they forget the half of them. So that is important for them. And the monitoring, that is a very important thing for the patients, how many times they need to go to the hospital or to see the physician. So that are the factors that we need to take into consideration. We want to choose a treatment for the patients. What are thinking about the physicians? The physicians are thinking another way. They think about mechanism of action, patients not. They think about monitoring requirements, they say like the patients, but they think about safety and they think about how long will be the treatment response. And very important things, they need to follow the product label, and very important thing, the treatment sequencing. So that's as I told before. You always need to think not about only the first treatment. You need to think about the whole plan, yeah? Because perhaps you are using a treatment and later after this treatment, you cannot use other ones, or you need to take into consideration, for example, that when you are treating with this treatment, later patients they cannot become pregnant direct, so that you need to switch again. So it is very important always to think about the sequence of the treatment and to think in the long term, not only in the short term. And about the physicians, they think about radiological efficacy and also about the disease and treatment history. And that is important always because we know our patients. It's always important to know the disease history, yeah, how was in the past and how is in the present of the patient. Here are the most important paradigms, yeah. So normally we have this always like this controversy, yeah. Escalation versus induction, that I will speak now. Maintenance therapy versus reconstitution therapy, immunomodulation versus immunosuppression, or platform treatments versus high efficacy treatments. I will speak about all these points with the exception of immunomodulation versus immunosuppression. First of all, when you have a patient in front of you, now there are two ways to treat this patient, escalation or induction. So when you see here the chart, you can see here like a ladder, yeah, you see like a stairs or ladder, the green line, and you see that is the escalation way, the escalation approach. It means you start with a treatment, the patient stays some years with this treatment. After this, you switch again, you have another treatment. Patient stays some years with this treatment, you switch again, and it's again with this treatment. And it could be now that perhaps after 20 years, you decide to do de-escalation. So to go for another more safe treatments, for example, when the patients are 60 or 70 years old. That is one way. The other way is the induction. In general, they will be less used the induction, but probably the times are changing and we will use more and more the induction therapy. Induction therapy is normally that you use a treatment very strong at the beginning and later you use a maintenance therapy or you have the patients without treatment. So that we will see now. Here is the most typical, is the escalation therapy. And we are from many years now thinking always about the escalation therapy. So it means when you are in the escalation therapy, you are always thinking how you will go in the ladder, how you will go in the stair, first step, second step, so that in the first line therapy, you have here the first line, interferons, and the orals. Later you have a second step, fingolimod, natalizumab, so the monoclonals. Later you have a third step, rituximab, mitoxantrone, and later the transplantation. That was always the classical way. So we escalate one by one and a little slowly way. So that's Gavin Giovannoni was doing in this way in 2018, so that we have different ways. Yeah, we can escalate in the two ways. We can do a conventional classic escalation. So first we wait, later we go only for the platform therapy, later we go for Mavenclad and fingolimod, and later for the monoclonals. And that will be the escalation therapy. And that is here important because always when you have different steps, you always need to think about which treatment are you using that allow you to use another treatment later, as we will say later, we'll see later. And there is another way to escalate, that is the rapid escalation. And nowadays we are using more the rapid escalation. So that you use one of the orals, but later we use direct Mavenclad and fingolimod, or sometimes you use direct, you don't use Mavenclad and fingolimod, so you jump from the platforms therapy to the monoclonal therapies, and you don't have Mavenclad and fingolimod, so that you have only 2 steps, platforms therapies and later monoclonal antibody. That is many neurologists are using now this rapid escalation. And now here going to what Gavin Giovannoni is saying, that is the flipping the pyramid, and it means that you are using first a high efficacy treatment, and later you go to another treatment that is not so powerful. So that at the beginning you can use one of the monoclonals, fingolimod or Mavenclad, and later you will use something like in the platform therapy. It's completely under a way to think. I am not saying that is induction. I'm saying only you are flipping the pyramid so that you start with a very high efficacious treatment, and later you go to a platform therapy. So that is the 3 different ways. I will say that the most of neurologists now are using the rapid escalation, or they are using this flipping pyramid, this early top. So hit early with an aggressive treatment, and later you go down and you de-escalate the patients. So that is one of the things that I was speaking about, the escalation therapy. And I told again, there is the induction therapy. Normally, when we are using the induction therapy, we are using induction therapy with cladribine, alemtuzumab, and the transplantation. Normally, the induction therapy, there are 3 treatments that they are short courses or pulse therapy. Normally, they are very high efficacy. They are irreversible. That is very important. And normally you use when you want to do, when you have breakthrough disease. One important thing, normally when you are using these induction therapies like alemtuzumab or cladribine, you don't have a rebound activity. And that is very important, because I will speak later, when we are using other treatments and we are thinking about to do the sequencing of the treatments, you need to always to think about the rebound activity. So, but when you are using induction therapies, one of the advantages is that you don't have a rebound. Other important thing with the induction therapy is that normally you can plan the pregnancy normally, because you need to wait, but later the patients, they can become pregnant after 1 or 2 years, depending on the treatment. And with some of this treatment, we can think about a remission period, like for example, in the cancer field. Yeah. For example, with alemtuzumab, you have patients that you treat 2 years and later they are in remission 5, 6, 7 years without any treatment and without any relapses or lesions in the MRI. That is the other concept. First, we were speaking about escalation versus induction. And here we speak about 2 other controversial, what is better to have maintenance therapies or immune reconstitution therapies. The maintenance therapies, they are treatment that we are giving continuously, like for example, all the monoclonal antibodies, for example, not all, but for example, monoclonal antibodies like tisabri or natalizumab or ocrelizumab or rituximab. And we have the immune reconstitution therapies that will be treatments like alemtuzumab or cladribine, so that you are given impulse and you are doing a transient immunosuppression. That is not a permanent immunosuppression. And that sometimes this transient immunosuppression, they has some advantages, because you are not always doing a permanent immunosuppression. So it means you have less adverse events, you have normally less infections. So here is only to show both kinds of therapies, the maintenance therapies and the reconstitution therapies. And as I told before, normally with the reconstitution therapies, you have less rebound activity and you have normally less infections. So that was regarding that the ways to treat, the ways to sequence the treatment. So we can do escalation, we can do rapid escalation, we can do induction therapy, or we can use, for example, for the escalation, we can use the maintenance treatment, like for example, ocrelizumab and natalizumab, or we can or platform therapies, or we can use the induction therapy with alemtuzumab or cladribine, or in the past with mitoxantrone. So, and now I will explain about some guidelines that they are thinking about this, and that is the guidelines from ECTRIMS EAN in 2018. There will be new guidelines, but they are not published. They were only some slides in the last exchange. Now they will be published probably now, 2022. But in the last ones, they have written that when you have a patient with a poor response, you can escalate to a higher efficacy DMD. And when the higher efficacy is not working, or if the higher efficacy is not working, you can consider another high efficacy DMD. So that they are speaking about de-escalation therapy. In the new guidelines, in the new recommendations that they will come probably, as I said before, 2022, in these new guidelines, they will speak more about induction therapy, and they will speak more about to start the treatments with a higher efficacy treatment and to start from the beginning with a more aggressive treatment, so that they will change the way to see how to treat the patients. Here is another algorithm. That is an algorithm from Sorensen from 2018. That is, they are speaking more about the escalation therapy, and later they go to the off-label therapies. And here is the UK treatment algorithm. And this UK treatment algorithm from Professor Giovannoni, that is similar to this thought about the flipping pyramid, so that patients, as you see first, patients with a clinical isolated syndrome are very mild relapsing remitting MS. He will start with a platform therapy or with alemtuzumab, and later he will escalate. But patients with a rapid evolving, with a very aggressive treatment from the beginning, he will start with an induction therapy. And after the induction therapy, he will think about to have a platform therapy, as you can see here in the chart. So that they are presenting like 5 different possibilities. So from patients, clinical isolated syndrome only with lesions, clinical isolated syndrome with lesions and symptoms, patients with a mild MS, and patients with a moderate relapsing MS, and patients with an aggressive MS. That is here another algorithms, and here is a little more general. That is, say you have a patient, and you need to look about the risk of these patients. For example, with prognostic factors, bad prognostic factors. For example, male is a bad prognostic factor. To have a lot of lesions in the MRI is a bad prognostic factor. To have infratentorial lesions, to have spinal cord lesions, so that you look at the risk of your patients, and later, as they say in the chart, you choose a therapeutic strategy. You can go to the escalation therapy, or you can go to the induction therapy. So that will be another possibility. And as I told you before, in the new guidelines from the ECTINS EIN, it will be another possibility, that is not to escalate direct with a platform therapy, so that you can start with a highly active treatment like the monoclonal antibodies, and later you can de-escalate. So, and here is another that is from 2019, another algorithm, how to do the sequencing of the treatment. They say you choose a treatment, and later you sit to monitor the treatment, and later go to another treatment, and always monitor disease activity, always monitor safety, and always look at the individual lifestyle is very important under the pregnancy. So when we want to do a sequencing of treatments to high efficacy treatments, we need to take into the consideration different things regarding the different treatments. For example, when we want to think about to escalate to the fingolimod, for example, we need to take into account that, for example, these patients, they cannot become pregnant, and when they want to become pregnant, they need to stop the treatment. And we need to take into consideration that these patients, for example, they can have a little bradycardia or macular edema, so that normally when we have patients with comorbidities, so health comorbidities or some ophthalmological problem, it's better not to have fingolimod. For example, when we have patients that they have autoimmune disorders, perhaps it's not good to start with alemtuzumab. Or when we have, for example, we want to have patients that they want to become pregnant very, very fast, that will be not better, for example, to start with cladribine, because with cladribine, you need to wait 6 months after the last dose. So that you always need to take into account all these factors to decide which will be the next treatment. Very important. So, and here, when we are thinking about how to decide, which will be the next treatment, one important point that I put here in red is the potential drug issues. So that is really very important. You are with one drug, you want to switch to another, And you need to think about different issues like tolerability, safety, monitoring, and drug effects. But really very important, PML risk, immunosuppression, and rebound and carryover. That is really very important. And from the beginning, when you are using the first treatment, you should think about what will be later and what will be later, yeah? Because the treatment is, as I said at the beginning, is for the whole life. Other things that you need to think about is lymphopenia, cardiac concomitants, hepatic concomitants, and other personal factors, as I was spoken at the beginning. Yeah, but very important, these things like PML risk, carryover, PML, sequencing, and rebound. So and here is a very interesting article that is from 2016 that was thinking about what is the problem when you have a patient that is with natalizumab, a high GC virus index, and you have the patient has a high risk of PML, and you want to switch these patients. What is the problem? The problem are normally two problems. One, you have the risk of carryover and asymptomatic PML to another therapy, or the second risk is to have a rebound disease activity. So that is really very important to take into account these two things when you are treating patients with natalizumab and you want to switch. So that you know that the risk of PML is we have this algorithm, and you see here the risk depending on the index, and you can and the European community, the EMA, they have done a recommendation when you are treating the patients with natalizumab. So that you need to do MRIs, you need to do GC virus testing, and depending how is the index, you need to do more MRIs, more testing, and different things. So that is important because we have these recommendations for the EMA in the case that you have patients treated with natalizumab. So, and what is the problem? So we want to have, for example, we want to switch from natalizumab to alemtuzumab. And here, that was from the 2018, they were thinking about how to do in the way that you don't have a rebound, but you don't carry over the PML. So, and they were different strategies. They say, okay, we can go from natalizumab to alemtuzumab direct, but when we have a very short washout period, we can have we can carry over a PML. We have another possibility is to have a longer washout, but here we will have probably a rebound. And the last one is to have a bridge agent, so that in the middle we can put TMF or fingolimod. That was the ideas in 2018. So my personal opinion now is always better to go from natalizumab to alemtuzumab direct and to try to do a very, very short washout, no more than 8 weeks, and always to do an MRI 2 or 3 days before the alemtuzumab to be sure that you are not carry over a PML. So to have the option 2 and the option 3, I think they are very bad options, and normally later you have a relapse or a rebound. So that I cannot recommend the option 2 and the option 3. And what I can recommend is always a very short washout. Here is this paper regarding the same subject, and they have patients with a GC virus positive with natalizumab, and they have stopped natalizumab in these patients, and they wanted to switch to ocrelizumab. And at that time point, they were thinking about the both things. Once the rebound and the other side, the PML. So the carryover PML or rebound. So that they have thought, okay, we want to do 2 different strategies. Yeah. So what they have seen first, the patients that they were direct switcher between natalizumab and ocrelizumab. So with a very short washout period, 2 of these 42 patients, so 2 of the 42 patients, they have a carryover PML. But they have seen that to avoid activity is better to do this direct switcher. So here they were the protocol. They were patients coming from direct from natalizumab to ocrelizumab with a very short washout period, no more than 8 weeks. Normally they have switched in the week 6. So, and they say that when you switch in the week 6, you have no possibilities for rebound, and you have less activity and less relapses in the next year. When you switch from natalizumab to ocrelizumab, in the middle, you are doing a platform therapy or cladribine or fingolimod. Normally, these patients, you are de-escalated, and normally these patients, normally they don't have a PML, but they have a rebound or they have an increase of activity, so that they recommend to do the direct switcher. So from natalizumab to ocrelizumab, and only to leave 6 weeks washout period. Here is the other problem. The other problem with natalizumab, with fingolimod, sometimes with Tecfidera, is that you can have a rebound. So for this reason, for example, we have published this in the 2070, as you see, because we have seen a lot of problems treating patients treating with natalizumab and at that time point from natalizumab to fingolimod. And the problem was that we were doing a long washout period between 8 and 12 weeks, and we have 4 catastrophic cases of natalizumab, of rebound with natalizumab. So that I recommend to do always a washout period between natalizumab and the next treatment less than 8 weeks. And the best will be 6 weeks, as in the article with the ocrelizumab. And here there are another articles highlighting, remarking the importance of the rebound. That is very important to do a very short washout. And as you can see here, with a washout of less than 1 month, there was no activity, no rebound. But when you have a washout of between 3 and 6 months, you have a rebound and you have more activity. There were patients changing from natalizumab to fingolimod, so that they recommend to have a very short washout between 1 month and 6 weeks. And that is the same. There are a lot of articles speaking about the fingolimod rebound. That is very similar, like the natalizumab. Patients that they are with fingolimod, we stop fingolimod, and we wait more than 6 weeks to start other things like cladribine or to start natalizumab. And these patients, they can have a rebound. So that I recommend to have always between fingolimod and the next treatment, no more than 4 weeks of washout period. And here, that is another article that is from last year, from 2021, thinking about how to do, for example, when you stop natalizumab due to GC virus and you want to switch to ocrelizumab or to fingolimod. And they have seen that it's better to switch to ocrelizumab, because when you switch to ocrelizumab, you will have less activity. When you switch to fingolimod, you have more possibilities to have more activity or to have a rebound. And regarding the safety, was very similar, and they were doing a short washout period between 4 and 6 weeks. But the most of them, as you see here, there was until 6 weeks, no more than 6 weeks after natalizumab. And in this treatment, there were no PMLs. They were doing in this way, patients from natalizumab to fingolimod, natalizumab to ocrelizumab, and there were no PML, and the washout period was 6 weeks in the most of the patients. And to finalize, one of the other problems that we are having now with sequences, that is the problem when we are doing, when we stop and one anti-CD20, ocrelizumab, rituximab, or in the next ofatumumab, but more for ocrelizumab and rituximab, there are some patients that they have a very low IgG levels, and sometimes that is the reason why they stop the ocrelizumab. And the question is how to do later. So what will be the right therapy in patients that they have a low immunoglobulin levels? That is very difficult. There are very few publications in this direction, and the most of them they recommend to go to natalizumab, because normally you don't have problems with the immunoglobulins, but they don't recommend to go to fingolimod, to Mavenclad, because normally in this with these patients in fingolimod you have the lymphocytes in the lymph node, in the lymph ganglion, and in the cladribine normally the targeting is B cells too, so that the switch from ocrelizumab should be regarding the patients that they have low immunoglobulins. They will be the best switch from ocrelizumab to natalizumab. And with all these things, I hope that you have understand. At least I have tried to be clear regarding the sequence of the treatments, that you can use escalation and induction, but nowadays the most of the many neurologists are using the rapid escalation when they are not using the induction. And now there are other ways of escalation that they will be in the next recommendations, is that you can start with a very highly active treatment like the monoclonal antibodies or fingolimod or Mavenclad, and later when the patient is stable, you can de-escalate to a platform therapy or to a less aggressive treatment. So, and regarding the sequencing, you always need to take into account the adverse events. You need to take into account the PML, the rebound, the low immunoglobulins, the preferences of the patients, and the things like safety and efficacy. Thank you very much. And now I will show you the 2 cases. So, one moment.
So I will ask our audience just to vote whenever
Yes.
Professor Celia will share the questions related to the cases. So our session will be an interactive one.
Yeah. So, one moment. Sorry, it was not the right one. Now will be better. So I will do now. Yes, now I have better. So here is one of the cases, and you can see now that is a case of one patient that she is 2070. She has a first relapse. She has a sensitive relapse, as you can see there, sensible relapse, as you can see there, mild with an EDSS of 2. She had 5 days methylprednisolone. She has only 5 lesions in the MRI. There were no lesions, infratentorial lesions. There were no gadolinium-enhancing lesion, and there were no spinal cord lesions. So there were only 5 lesions, oligoclonal ones positive, and a very mild to moderate relapse. So that we have treated these patients with Auvallo. The patient has no comorbidity. She has 1 child, and she was working in an office. And later, 2019, so 2 years later, the patient is coming from 5 to 15, more than 15 T2 lesions. So that we were treating these patients with Auvallo, and in 2 years, she has much more lesions. So 15, more than 15 T2 lesions. Some of them, they were infratentorial, so it means bad prognosis. And she has 1 gadolinium-enhancing lesion. So that's the number of the lesions. They were much more than 2 years ago, and we have infratentorial lesions and we have gadolinium-enhancing lesions. The question is now, how would you approach treatment for this patient? How you will do this for this patient? One moment. This is the MRI. And which treatment you will give for this patient? Please vote. I vote, please. I don't have now not the results. We are waiting for the results. I don't know if, can I see the results?
Yes, I will share the results now.
Okay.
Let's wait
Sorry.
10 seconds.
Yes, okay. We wait.
Now, 5 seconds left. I would recommend and encourage everyone to participate.
Yes. Okay, that is, I see. Thank you very much. Okay, I see that is there are different options. As I see, there are different options, and most of you will treat the patients with natalizumab, others with fingolimod, others with ocrelizumab, and others with cladribine. So it's really, so I will say most of you will be treating with natalizumab or fingolimod. So what we will do, so that we have treated. I don't know why it's not working now. Now, we have treated these patients. The patient was GC virus negative, and we have treated these patients with natalizumab because we thought in 2 years there were a lot of new lesions, and one of them was infratentorial, and they were gadolinium-enhanced lesions, so that we thought we have an increase of activity of the disease, so that because the patient was GC virus negative, we have decided to start with natalizumab. It's very clear when in the case that the patient was GC virus positive, there are other options, and in this case, in particular in this case, if the patients will be GC virus positive, I will treat these patients with an aggressive treatment like ocrelizumab, and I will not treat with the orals at the beginning. Only when the patients they have some problems with the IV treatment, with the monoclonal treatments, or when they have other factors. But all of the 4 treatments, they were possible. you need always to speak with the patients, adherence, and other things. So, and later these patients, she was with natalizumab, and as you see here, 2 years later, she has a second relapse with a severe optic neuritis right. So very severe, she could only see 10% in the right eye, and the patient, and we have decided to switch the patient again. So patient was with natalizumab, and she has a very severe relapse with an optic neuritis right. How will you approach for this treatment? Now we have again five different options. Always all the options are possible. Please, you can vote.
Uh, 30 seconds left.
Yeah,
I
no
would
problem.
encourage everyone to
Yes, okay.
participate.
Yes.
10 seconds now. Okay, now I'm sharing the results.
So we see here that most of you will go for ocrelizumab. That was our option 2. We have treated the patient we have switched from natalizumab to ocrelizumab. You can remember this article that I have showed you that in cases that you have natalizumab, one good option is to go to ocrelizumab because you have less activity. So and you need to have a short washout period, no more than 6 weeks. Other possibility, I think, for this patient will be a good, so to keep in natalizumab, I don't see this possibility because normally the patients with natalizumab, they don't have relapses, yeah? When they don't have relapses and the patient has a relapse, it is almost mandatory to switch the patients from natalizumab to another one. So that I think the two possibilities, they will be ocrelizumab and the other possibility will be alemtuzumab. I think both possibilities, ocrelizumab and alemtuzumab, are possible. We have switched the patient to ocrelizumab and now is still going with ocrelizumab without any relapse. Going to fingolimod and cladribine, I will not see so good because you will de-escalate the patient and the patient is active. We have seen before between the first relapse, after the first relapse, it has a lot of lesions in 2 years with Auvallo, so that I will go for more aggressive treatment. So I will go for a monoclonal antibody like ocrelizumab and alemtuzumab in this patient. And as I have showed you before in this article, with patients coming from natalizumab to fingolimod or ocrelizumab, they recommend to go to ocrelizumab because you will have less activity. So that was the first case, and we go now short to the second case. I see where is the second case. One moment. Here's the second case. So that is a completely different way. That is a woman, 34-year-old, secretary, a very active lifestyle, healthy, married, no children. She starts with a very mild optic neuritis, and she recovered completely without treatment. And 2060, and 1 year later, the patient had a numbness in the left hand. So she has some problems with tingling in the left hand. And now comes the question, we can treat or not treat the patient. I will say we will treat the patient, but how we will treat this patient? And when we want to treat the patient, how you will do? You will do with an injectable, with an oral treatment like fingolimod, teriflunomide, dimethyl fumarate, or cladribine. So please vote. It's a patient with a relapse 2016 with a complete recovery, and a second relapse 2070 that was moderate relapse.
10 seconds left. I'll stop the poll now and share the results.
Yes. Okay. Now, okay, it's really a lot of possibilities as I see, and with different possibilities. So that we have thought in these cases because was I see that you put all the 3 orals and interferon and cladribine, and the last one is cladribine acetate. So you need always to speak with the patients, look at this, perhaps they want to become pregnant again because she was without children. In this way, they will good to have an injectable or dimethyl fumarate when it is in a short term. So that in this case, we have decided to go for, sorry, I don't know, here. We have decided to go for dimethyl fumarate because we thought it's for a platform therapy and injectable. The patient has 2 relapses, perhaps is perhaps not enough to have an oral platform, an injectable platform therapy. So we have decided to have an oral treatment. And so we were thinking about perhaps the patient want to become pregnant, so that we have decided to have an oral treatment and she can become pregnant, and that was easy for her. What was the problem is 1 year later, she have again a relapse. So that's really, when I see now retrospectively, the dimethyl fumarate was not the best option. So probably the best option was, as some of you votes, fingolimod or cladribine, but probably with dimethyl fumarate, we were undertreated, and that was the reason why we have in less than 1 year, the patient has again a new relapse. So that now we have the patient, she's with the dimethyl fumarate and she has a relapse, a new relapse. What you will do now? This relapse was again sensible relapse, moderate. There was not motor. This was not a motor relapse. So that the patient, both of the last relapse, they were a sensible relapse, only with some tingling or numbness.
5 seconds left. Okay, now I'm stopping the poll and sharing the results.
Okay, we see now the options. Okay, so it's very interesting. Most of you are going for really very strong treatments. So I think you are right. So at that time point, we have switched to cladribine because it was not very clear if the patient wanted to become pregnant or not in a very short time. And we have done cladribine, but I think all the possibilities are right. And now, retrospectively, I think that there was, as you say, it was a good option to go to a monoclonal antibody like natalizumab or ocrelizumab. Or in the case that an oral, you prefer to have fingolimod and cladribine, so that I will think the same. So that I think in this patient will be better to have a monoclonal antibody like natalizumab or ocrelizumab, and in second case, fingolimod. So we go to the next one. So, but at that time point, we were thinking about that perhaps she wanted to become pregnant and she wanted to have an oral. Now I cannot say, I don't know why I cannot go. Okay, now, so that we have decided to switch to cladribine. So we have switched the patients to cladribine, and she was until now, from March 2019 and until now, without relapses. So retrospectively, I will say our first treatment option in May 2017 was not the right one, the dimethyl fumarate, because less than 1 year it has a new relapse. But when we have started with the cladribine, later until now, so 3 years now, the patient is still with cladribine. Only in the time of the COVID, we were thinking what to do, because at that time point in March 2020 was a lot of COVID in Madrid, and there were no experience, and we were thinking about what to do to treat with Mavenclad, to continue with Mavenclad or not. And so at that time point, we have that was the problem with the COVID. Patient was with Mavenclad, was the patient with the COVID. and we were afraid, and we didn't know what to do, to continue with Mavenclad, to go to fingerling mode, or ocrelizumab and natalizumab. Please vote, and that is the last one.
Five seconds left. Okay, now I'll stop the poll and share the result.
Okay. So here was the question more because of the COVID. So so that we have later decided there is no problem with the COVID, so that we have decided to continue with cladribine, and that was not a problem. What I will not do was to switch to ocrelizumab, because patients with ocrelizumab, or in general with anti-CD20, they have more risk to have a bad course of COVID. So that I think from all three, the less indicated treatment in this point with the COVID was the ocrelizumab, but all the three are possible. And at that time point, we were not a little afraid what to do, and we have decided to continue with cladribine. So that was the last case. Thank you very much for the attention.
Thank you, Professor Celia, for a very enriching presentation and very interesting case discussions also. So I don't want to delay further Dr. Raed Roghani lecture. However, I will take only two questions. So the first question, what about the safety of natalizumab during breastfeeding?
So, okay, so and we are not doing, I will say, but in some countries like Germany, they are doing, because the monoclonal antibody, normal monoclonal antibodies, they are big molecules, and normally they cannot through the milk normally. So that's could be, so in the SMPC is written, is not written. So that's in countries like Spain we are not doing, but in countries with like Germany, that they have a lot of experience, and they keep natalizumab during the pregnancy until the week 32. Later, they allow the patients to continue with natalizumab during the breastfeeding, but that is clear off-label, and they can do off-label in Germany, and they say they are no problem because the molecule is not coming through the milk. But in countries like in Spain, we need to follow the SMPC, the technical file, so that we cannot do, because it's completely off-label.
Yeah. So another question, now that ofatumumab is a newly available or a recently available DMT, what is the washout period between natalizumab and ofatumumab? So if a patient is failing natalizumab, or if he completed his 2 years of natalizumab and he has positive JC virus, what is the washout period?
So I will not do more than 4 weeks. I will do between 4 and 6 weeks, but no more than 4, so no more than 6 weeks. I will try to do 4 weeks, and only when it is not possible, I will do 6, but I will try to do only 4 weeks. And very important, I will do an MRI 2-3 days before the ofatumumab. So very, very close to the ofatumumab, but I will not wait more, yeah, because it's like the same like with ocrelizumab. With ocrelizumab, normally we do 6 weeks. So with ofatumumab, I will do between 4 and 6 weeks washout period. No more than 6 weeks. Otherwise, you can have probably a rebound. And to avoid the PML, very important to do the MRI only 2 or 3 days after, 2 or 3 days before ofatumumab.
Maya,
and
I have a question to Celia.
Okay.
Yeah, sure. Go ahead, doctor.
Right.
Thank you, Celia, for your great presentation. Regarding the case who was on natalizumab and then developed severe optic neuritis, would you think about re-investigating her as well? Because it's rare to have a severe
Yeah.
relapse on natalizumab. And
I know. It's very severe, yeah. But we have this last year 2 patients. This another one that have a motor ring. So we were thinking about that. Perhaps probably this patient has antibodies, so anti-natalizumab antibodies. We thought, but normally we are not doing more. At the beginning of the natalizumab, we were doing this every 6 months, but later we have realized that it's very expensive and cost a lot of time. So normally you don't have problems with the efficacy of natalizumab, that we have stopped doing antibodies, so natalizumab antibodies. But our thoughts is that probably that was probably the patient has natalizumab antibodies, probably, but that was not a PML. Probably that was natalizumab antibodies, and that was the reason why there was inefficacious. Normally, as you know, as you said, normally our patients that we switch from natalizumab to another one, normally it's because of the GC virus positive, but not because of the efficacy. And in this case, we think that that was probably he has a natalizumab antibodies, and that was the reason why failure the natalizumab. But we were not checking because we cannot do more, because in the last years we haven't done any more.
okay, thank you.
And another final question: strategy if a patient developed lymphopenia on fingolimod, lymphocytic count in ALC below 200.
I cannot understand. The question is?
Yeah. What is your strategy if a patient develop a low lymphocytic count while on fingolimod treatment in ALC below 200?
200. Okay, when this is under 200, I stop fingolimod. That is the first thing. I stop the fingolimod, and when this is less than 200, normally I give some weeks acyclovir or valacyclovir or something like that to avoid to have an herpes zoster. Yeah, so when this is 190 not, but when this is 150 or so, I give an antiviral like acyclovir, valacyclovir, fanciclovir, one of them. And I stop the fingolimod. I wait if the patient, if the lymphocytes are coming higher, I increasing in 3 or 4 weeks, and when that is not, I switch the patient. So when in 4 weeks the patient has not a normal, at least 500-600 lymphocytes, normally I switch the patient to another treatment. For example, to natalizumab or natalizumab, that normally you don't need. That is not a problem when you have low lymphocyte count.
Yeah. Thank you, Professor Celia, for being with us today and for an excellent presentation. So I will move to Dr. Raed Roghani, our second MS expert from Kuwait. Thank you.
Thank you.
So
there will not be more questions at the end, or there was the questions they were now?
No, I took all the questions.
Okay, thank you. Okay.
Thank you, Professor. So our second multiple sclerosis expert is Dr. Raed Al-Roghani from Kuwait. Dr. Raed Al-Roghani is a consultant neurologist and the director of the MS clinic at Amiri and Ibn Sina hospitals. He received his degree in medicine from Charles University. He completed his neurology residency at the University of British Columbia and subsequently obtained the neurology certification from the Royal College of Physicians and Surgeons Canada. He then completed a fellowship in multiple sclerosis at the University of British Columbia. Dr. Raed Roghani fields of interest are principally directed toward the epidemiology and therapeutics of MS. He established the National Multiple Sclerosis Registry and the Multidisciplinary MS Clinic in Kuwait. He authored and co-authored more than 150 publications. Dr. Al-Roghani was awarded the National Prize for Scientific Production in the field of medical science in 2017 and the Best Researcher Award by Amiri Hospital in 2018. He is a founding member and the General Secretary of the Menectrums. He is the Vice Chair of the Scientific Leadership Group of the MS-Based Foundation and an executive board member of the Paradigm MS Foundation. He sits on the executive boards of various scientific associations, steering committee and advisory board, mainly in the field of multiple sclerosis. Dr. Al-Roghani will discuss the current and unmet needs in MS, as well as the treatment guidelines for escalating therapy, and will share with you clinical cases for discussion. Dr. Raed, you are the most welcome. Please start your presentation.
Thank you, Maya, for your kind introduction. I also should thank Novartis for the invitation. So I think Professor Celia already alluded to the treatment evolution and the importance of escalation. And you can see lots of medications being going and being approved, and also a few to come in the next few years. Now, also, Celia talked about what we feel is an escalation ladder where we go first line, second line, third line. I think we all agree that we have to choose the right medication at the right time for the right person. And we're going to check the efficacy, the safety, the convenience, the tolerability, and all these will probably going to be a big factor in your decision. Now, the problem with MS is how soon should we treat? We know that MS is a chronic illness, and if you leave it, it's probably going to progress. So it's a progressive illness that we cannot predict the transition to progressive MS or secondary progressive MS. Now, the quality of life is always being hit hard by MS. The most common, quality of life symptoms are fatigue and also some psychiatric illness like depression and anxiety. And also with increasing disability, you will see ambulation difficulties, employment impact, and also cognitive impairment. Beside all this, pain is a major factor in MS, and you all know there are lots of neuropathic pain, sometimes trigeminal neuralgia, and other sensory symptoms like tingling or burning sensation. Now, we need to hit the disease very hard, because if you see the employment rate, it's actually declining with the increment in the EDSS score. Once you reach EDSS 5, 6, then there's more than 2/3 of patients are unemployed. So you really need to delay this progression as early as possible. Now, we all talked about safety and efficacy. These are two important things to the healthcare providers. Of course, there are other options that are very important to the patients, like quality of life, the convenience. And so this is your decision when to actually take your bullet and decide on which treatment you're going to start. And Celia already alluded to many factors, and she showed us why efficacy is very important and why safety is important. Now, the options are many. You have the IV infusions, you have the oral therapies, and you have the sub-Q therapies. And each of these medication has its cons and pros. So I think it's your decision to communicate and discuss all these factors with the patients, and then it's a physician-patient shared decision making at the end. Now, why we need to really start medication or the treatment very early? We all know from the historical studies that number of relapses, especially in the first 2 years, make a big difference to the progressive course. So, for example, if you have one relapse in the first 2 years, the mean time to reach EDSS 6, which is time to a cane, is around 22. However, if you have 3 relapses or more, this time will be reduced to 15. So you need to really shut down the inflammatory component of MS really early in the first 2 years. Second, the MRI lesion, and we all talked about the lesion load at the beginning of MS, especially at the baseline. If you have more than 7 lesions, you are talking about a fast progression or conversion to a secondary progressive MS. And so you really have to take extra care when you look at the MRI. It's not just the clinical presentation. MRI makes a big difference. It's so far the best surrogate marker that we have in hand at this stage. And not only the delay in the treatment may make a difference in the quality of life, but also there is a unique, what we call milestone. Once the patient reached, then the progression will start fast. And this milestone is 4. In some studies, they may mention EDSS score of 3, but every patient has his own unique turnover or a score where they progress fast. So if you can see, if you delay treatment for a year, you can see the curve is actually not bad as for progression. But if you decrease you delay the treatment for more than 3 years, you can see there's 50% chance that the patient may progress within 5 to 6 years. So it's really need to tackle the disease as early as possible. Prior to the McDonald's criteria, we were using POSA criteria, and most physicians were reluctant to treat patients unless they have 2 relapses. And then with the CIS definition, some physicians were reluctant to start even with the first relapse. Nowadays we have RIS, and probably it's gonna have this time in probably in the next few years where we're gonna treat RIS as well. So as you know, the new McDonald's criteria, CIS is very rare, and probably we are treating now all MS patients as early as possible. Why treatment earlier in the disease makes a big difference? If you look at the studies, if you look at the historical study with the interferon and glatiramer, and even if you see the pivotal trial, the long-term survival data or the long-term data for both interferon and glatiramer acetate, you can see that those who were on treatment had a lower risk of transitioning into SPMS compared to placebo. As you know, in the pivotal trials, patients were not treated for 2 or 3 years and then switched to the treatment arm in the open label studies. And you can see the difference starts from the beginning. So the first 2 years are probably very important to reduce the risk of SPMS. And nowadays we all talk about no evidence of disease activity, NEDA. And our target at this stage is to achieve NEDA. And why this is important? Because if we stop the progression and we stop the inflammatory component clinically and through the MRI, we are probably limiting the progressive course at higher percentages. Sure, we cannot shut down the progressive course completely, but at least we have a better option to control the disease for a longer time. And when we talk about NEDA, we are talking about absence of relapses, absence of any disability progression, and absence of MRI activity. So this is our target nowadays, although the ultimate target is to shut down the progressive course. Now, progression probably gonna start at one stage in all relapsing remitting MS. And now I talked about the unique number of EDSS 3 or 4. And so we are trying to shut down or delay patients from going into EDSS 3 and 4. However, for those who progress without relapses, and this is what we call PIRA, this is probably the progressive course or the transitional period into secondary progressive course. Now, all relapses may have some residual disability, and they may have an increase in EDSS after a severe relapse, but yet they're going to stabilize after that, and this is what we call RAW, or relapse-associated disease worsening, and they usually stabilize after a month or 2 months or 3 months from the actual severe relapse. So you really need to differentiate between RAW or PIRA. And this makes a big difference because PIRA, you are talking about a progressive course, and there are only limited options when we talk about transitional or progressive MS. Now, is NEDA a reasonable measure on the long term? Unfortunately not. Most patients will probably break the NEDA3 or will fail NEDA3 with the long term. In a real world setting, and when studying around 220 patients in a Brigham and Women's Hospital, it shows only around 8% maintained NEDA3 at 7 years after receiving the first injectables. So you can see the injectables are not good candidates to achieve a good NEDA. However, if you do a long-term follow-up on patient receiving natalizumab, so a high efficacy medication, then you can see the figure increase significantly to 34% at 7 years. And probably if you recalculate this with earlier disease-modifying therapy initiation and stronger or high efficacy from early in the beginning of the disease, you're probably going to achieve better NEDA on the long term. Now you're going to hear NEDA 4, and it is it's the same as NEDA 3 plus the volumetric measure of a brain atrophy, or the addition of domain, other cognitive domain measures. The quality of life probably be used in some of the articles, and this will probably go into NEDA 5. And you will see NEDA 5, 6 later on. But I think NEDA 3 is the least we're going to goal for at this stage. Now, why we need to use highly effective treatment at disease onset? Because few studies, especially that one was done in the UK, showed that if you use high efficacy from the beginning and you compare it to those who failed and escalated later, the chance of reaching secondary progressive or reaching sustained disability progression is lower when you use high efficacy early on. And when we say earlier on, again, we are talking about 2 to 3 years from the disease onset. So the chance is even better if you go really on from the disease onset. So high efficacy medication, depending on where you read, but the newer medication are classified as high efficacy medication. And here we are talking about fingolimod, cladribine, natalizumab, ocrelizumab, alemtuzumab, and the new ofatumumab. So we consider all of those are high efficacy medication. So Celia talked about escalation, and this is sometimes being used as a conservative treatment, and especially for those with very mild to moderate disease activity. But once you have a high disease activity with 2 relapses or more in the first year, or a relapse with a high lesion load, or a severe relapse with residual activity, what we call rapidly evolving MS, then the best option would be to go into high efficacy treatment. And why this is important? Probably this is another way to delay the progressive course. So you always have to think about high efficacy medication, even in a patient who just been diagnosed. So I think if you take the patient factors, the disease factors, you're going to make a big decision shared with the patient on the long term. And why high efficacy medication are very important. If you look at the historical data for the beta-ferron, the interferon beta 1b, and if you compare placebo to the treatment arm on the long term with the 16-year follow-up, you're going to see no big difference in the patient who progressed to SPMS. So probably the first line treatment is not going to be a big factor here to change or to delay the progressive course. However, if you compare the platform therapy with high efficacy medication, you see a better risk reduction in those patients who converted to SPMS by at least 34% within 8 to 9 years. So early intervention may slow the disability progression in patients with SPMS. And I think this is being proven by real-world evidence, by long-term data, and also by comparative real-world evidence that comes from lots of literature data. Now, the last question that the last issue I'm gonna tackle is the diagnosis of secondary progressive MS. Unfortunately, most of the patients have delay in the diagnosis of SPMS. And this is across the globe. And before, I think most physicians were afraid of calling the patient SPMS because there were no approved treatment for SPMS. So we are trying to delay the diagnosis and use all the medication we have that were approved for relapsing remitting MS. And I think this is a mistake that we've been doing in the past. And nowadays, I think we have to be very cautious. We have to try and diagnose the patient very early with SPMS, especially once they reach what we call PIRA, or once they reach an increase in their progression to 4 or EDSS 4 or 5. We don't need the EDSS 6 to call a patient with SPMS. Probably we are a little bit late with this. So this delay is a big factor in those patients who are already not responding to any disease modifying, even if for the approved SPMS medication. So early detection of SPMS makes a difference. Maybe we would be able to at least slow down the progression. Maybe we can also delay the time to EDSS 6 or the time to the wheelchair, the 7.5. And we may also improve the quality of life if we get it very early. And the SPMS category nowadays, I think this is one of the unmet need in the MS arena. And the issue is the diagnosis, and the second issue is actually treatment. And nowadays we have treatment for SPMS. We have the Sipenimod, which is approved for secondary progressive MS, and we have ocrelizumab approved for PPMS. But other medication may work also for active SPMS as per the FDA label. So I think it's our time nowadays to try to ease the unmet needs, especially for those with progressive MS. Now, the diagnostic criteria, especially the McDonald's criteria, were all put together to diagnose relapsing remitting MS. And the diagnostic criteria for SPMS is actually controversial, and there is still no kind of consensus on how would you diagnose SPMS. And I think this is a major unmet need, although there are lots of encouraging papers to give us a hint on how to diagnose SPMS. One of them is actually the Lushander criteria, where you, if you have an increase in the EDSS by half a point, if the total EDSS is less than 5, and an increase of 1 point if the EDSS 5.5 or more, and sustained for 6 months. So if you have this in the absence of relapses, then you are pretty sure that this is likely going to be a secondary progressive MS. Now, the final slide before I go to the cases is the ECTRIMS guidelines. And again, there was a big emphasis towards high efficacy medications. And probably this is important to achieve the NEDA. And also it's important to delay the progressive course. And also there is also some concern about those patients who are switching. And I think Celia already alluded to the fact that some medications, especially those with the anti-trafficking agent like natalizumab and fingolimod, you have to be very cautious when switching because of the disease reactivation or even a rebound syndrome. So as Celia said, you have to really don't wait for more than 4 to 6 weeks from natalizumab discontinuation. And also once you have a good lymphocytic count after fingolimod discontinuation around 800, you probably need to start another medication. Now, the controversy is always in those patients who are stable on their disease-modifying therapy for more than 10 years. And what would you do? Would you de-escalate? Would you continue? Would you discontinue and watch and see? And I think we need more data about those who are very stable for more than 10 years. Probably this will come from the long-term data very soon. So I finished my presentation. So I have 4 cases, but I probably, because of the time, I'm going to go through 2 cases and see how things unfold with the time. So with case 1, I have 28 years old female who is healthy, married, and has 1 child. In 2010, she presented with optic neuritis, which completely resolved with IV solimidrol. However, historically, she had a left-sided numbness that lasted for 2 weeks and resolved spontaneously. Her exam was essentially normal with EDSS 1. So a diagnosis was established at that time, so 2010. So we only had interferons at that time and also natalizumab. So because of the early MS, she was started on interferon beta 1A subcutaneous. She remained actually very stable for almost 7 years. However, in 2017, she remained stable. I think there is a mistake. She remained stable for a year, and then she developed a myelitis. She had a bilateral pyramidal weakness in the legs with a T4 sensory level. And she improved. However, her ADSS increased a little bit after steroid to ADSS 2. So she went from 1 to 2. So at that time, the decision was to start either natalizumab, and at that time, 2011, also fingolimod was available. However, the JC virus was negative. This is her MRI after the myelitis. Now, if this would be a patient that is currently now, so what would you choose? Would you stay on betaferon? Would you go to other disease-modifying therapy? And we also know that her JC virus is negative. So what would be your option in treating this patient? So we are waiting for the vote results.
Yes, 5 seconds left. I'll stop the poll now and share the results.
Okay. I think any answer other than interferon would be correct. And that's why we know there is a disease reactivation while on first-line treatment like interferon. So changing a treatment is the right option, and escalation to high efficacy would be the best option. And so fingolimod, natalizumab, ocrelizumab probably are good options. And since she's JC virus negative, I think I agree with most of you that natalizumab would be the best option. So case 2, we have a 34-year-old female who's healthy, married, and has 3 children. And in 2017, she presented with left-sided paresthesia and weakness, which was progressive within 2 to 3 weeks. Her exam was very significant. She has pyramidal weakness, also a sensory manifestation, along with positive Romberg and spastic gait. Her EDSS is 4.5. She improved with Solimidrol. However, her EDSS remained at 2.5 after a month of Solimidrol. So we established the diagnosis. She had a complete workup. The mimickers were excluded. The oligoclonal band was positive. So there was no question of the diagnosis. So the question, this is her MRI. You can see high lesion load, almost tumefactive lesions, periventricular, juxtacortical, many guide-enhancing lesions, and also multiple spinal lesions. You can see 2 in the cervical cord, and there's 1 small one in the dorsal cord as well. So the next question, how would you treat this patient? Now you can always add cladribine and ofatumumab also to the options. However, here we are talking about the principle, not just one kind of correct answers.
I have 5 seconds left. I would encourage everyone to participate in the poll. Okay, now I will be stopping the poll and share the results.
Okay, so most of you again chose natalizumab. Second was fingolimod, and the third was ocrelizumab. And I think the main idea behind this case is this is what we call rapidly evolving MS, where there is a severe relapse with residual disability and very high lesion load and guide-enhancing lesions. So we are talking about rapidly evolving MS. You need probably high efficacy medication. And I think the top 3 chosen, natalizumab, ocrelizumab, fingolimod, are high efficacy medication. And this is I agree with most of you. Natalizumab, ocrelizumab probably going to be the top for me. And I agree with the audience. Some of you may do JC-VIR. If it is negative, they will start natalizumab. If it is negative, they may go on ocrelizumab. Now, alemtuzumab is also another option. If you think about rapidly evolving MS, sure, you need to discuss with the patient whether this is about the safety concern and the long-term monitoring. Teriflunomide and dimethyl fumarate probably not the good options at this stage. Let's go to the third case. I think we have time.
Yes, we have time, doctor. We can proceed.
Good. So this is a 26-year-old female. She's a dentist. She presented with imbalance and gait instability for more than 6 weeks. However, 1 year ago, she had what appears to be a right optic neuritis. This is her MRI. You can see there are more than 6 lesions in the brain and in the supratentorially, and 1 cerebellar lesion at the axial T2. Her exam showed right optic atrophy. She had left beating gaze-evoked nystagmus. Her cerebellar exam showed dysmetria with finger to nose and heel to toe on the left, and also slight dysdiadokinesis on the left. She had positive Romberg, ataxic gait, and veering to the left. So she received IV Solimidrol. She almost recovered. The MRI cervical spine was normal. The CSF was positive for oligoclonal band. So we established the diagnosis with relapsing remitting MS. Here we come, your treatment options. So again, a female with one relapse of optic neuritis historically, another relapse cerebellar. I showed you the MRI. Her OCB is positive. So how would you treat this patient?
Sorry, doctor, before taking the question, one of our attendees is asking Dr. Tfaili why you considered her rapidly evolving MS and not the primary progressive MS.
Which one? The previous case, you mean?
Yeah.
Okay, so primary progressive MS is it's a retrospective diagnosis. So you need at least 1 year of progression. This is number one. Second, GAD enhancing lesion with this amount of number of lesions is unusual for primary progressive MS. Third, she's a female. Again, female less likely to be primary progressive. Fourth, she improved after steroids. So she went from 4.5 to 2.5. So all of these factors are probably against primary progressive MS, and also the age, a little bit younger for primary progressive. Usually primary progressive in the mid-30s, male, a long history, very minimal response to steroid, and you don't see that GAD enhancing lesions in the brain. And plus, most primary progressive MS have lesions in the spine more than in the brain. So we label them as a relapsing remitting and rapidly evolving because of the residual disability on a clinical exam. Okay.
Okay, I'll stop the poll now for this and share the results.
Yeah. Okay. So most of you again voted for fingolimod and natalizumab as a second option. So let's discuss this case. I think the options are probably all going to be important. Now, she's a female. She has 3 children. So family planning probably is not going to be a big issue. So fingolimod might be a good option. Second, she has one of the poor prognostic indicator, which is a cerebellar attack. So again, using a high efficacy medication might be also a good option, like fingolimod or natalizumab or ocrelizumab. Some would argue that she's still in her early disease and dimethyl fumarate might be a good option, or interferon might be a good options, or even teriflunomide are good options. So probably you can use them, but the chance of them failing is going to be around 50-50. And if you go back to the case, let's go back to the case. She presented with a cerebellar attack, and then a year ago she had optic neuritis. So if you consider 2 attacks within a year, here you would hint that this is probably gonna be a highly active in the near future. So probably I would go with fingolimod or natalizumab or even ocrelizumab, because usually the inter-relapse time is not that high. If she had 2 relapses within 5 years, I wouldn't be that worried. But 2 relapses in a year, one of them is cerebellar, then I would probably use a high efficacy medication. So let's continue with this. So this patient started on Tecfidera, dimethyl fumarate, okay? And she had some mild GI upset. We used a PPI as symptomatic treatment. She was actually well for 24 months, so 2 years, with a good MRI result in the first 2 years. However, she got a relapse. She had a myelitis, and then we again started the treatment options. We did a JC virus, which was positive with high index. So 2 relapses in a year, one of them is cerebellar, then I would probably use a high efficacy medication. So let's continue with this. So this patient started on Tecfidera, dimethyl fumarate, okay? And she had some mild GI upset. We used a PPI as symptomatic treatment. However, she got a relapse. She had a myelitis, and then we again started the treatment options. We did a JC virus, which was positive with high index. the decision was to go is actually on fingolimod at that time. Again, her EDSS a little bit increased after her last relapse. So you could see this is sometimes we take a conservative option with Tecfidera, but I think this was a mistake, as with Celia case, when we started with a low efficacy medication and sooner within 2 years she developed a relapse. So probably using a high efficacy medication sometimes make a difference. However, I think family planning may play a big option at this stage. So I think this is case 4. Last case. So this is a male. In 2008, was diagnosed with relapsing remitting MS, but his EDSS at that time was 2.5 after the relapse. He was started on betaferon at that time and switched to natalizumab because of persistent relapses. You can see his MRI is heavy with the supratentorial lesions and also with the spinal lesions. Now, his EDSS in 2014 after his bad relapse was 5. And he received almost 2 years of infusions. The repeated JC negative was, the JC virus was negative until 2016 when his index became 3.2. So here we have a stable patient, however, with EDSS 5 on Tysabri with positive JC virus with the index 3.2. So how would you treat this patient? Now, for those who are going to ask, he was on 4 weekly dosing at that time, 2016. Now, some of you would know that now we are using the extended interval dosing of 6 weeks once the patient passed the 1-year period on natalizumab. However, for the sake of this patient, how would you treat this patient? Switch to other medication or continue on natalizumab? Let's see what do you think?
5 seconds left.
Sorry, let's go back.
Okay, I'll stop the poll now and share the results.
All right, so majority will switch on ocrelizumab, followed by switch to fingolimod. I think these both options were probably right at the beginning in 2016. Nowadays, most of the experts will switch to ocrelizumab or rituximab as an off-label. And why? Because there were 2 studies published, one in France and one in Sweden, comparing fingolimod and B-cell depleting therapy such as rituximab after switching from natalizumab. And both studies shows that B-cell depleting therapy following natalizumab would be better and on the long term in reducing the disease activation or the relapses on the long term. Now, alemtuzumab might be a good option as well. I mean, you have to consider the safety concerns and probably the carryover PML might be a big risk. So you may need to do another MRI or repeat the CSF before you switch to alemtuzumab, which is a powerful drug. Dimethyl fumarate is probably not a good option. It's a de-escalation. He was already active before going to natalizumab, so not a good option. Now, would you continue natalizumab? I think this would be an option if you don't have other medications. And probably with nowadays we have other options, and I wouldn't continue natalizumab at this stage. So with this, I just want to conclude that I think choosing the right medication, balancing the efficacy and risk tolerability is your main objective at this time, especially with the advent of many medications. Real world data gonna help us in our knowledge, especially when you compare one drug to another. High efficacy medication, as I showed you, are best when used early and when you escalate early, and also when you do the induction therapy. Probably this gonna reduce the risk of disease progression. I think the best when you use it early in young patient as well. With this, I'll thank you for your attention.
Thank you, Dr. Raed, for an amazing presentation and valuable case discussions. We will take some questions if you allow us. So the first question, if a patient has a history of PML on natalizumab and he has aggressive disease, MS disease, so what is the next option? So what is the strategy for treating a patient with history of PML on natalizumab?
Again, we are talking a very, very rare scenario. Good news is we haven't seen PML in the Middle East, and for almost now the last maybe more than 15 years, there's only one asymptomatic case in Saudi Arabia. So
this could highlight the genetic, probably, doctor, predisposition?
Probably the genetic predisposition, yes. And I think compared to the Eastern European or the North American, the likelihood of having a PML is very, very small. Now, this option is valid. Now, if a patient has a PML, probably you're not going to go on natalizumab or any kind of treatment that has high risk of lymphopenia. Because probably the trafficking issues with the lymphocyte surveillance are going to be a big risk. So probably ocrelizumab, rituximab would be the options. Cladribine might be an option. I don't think low efficacy medication are options. Why? Because he already was on, or the patient was already on natalizumab, so it's very risky to de-escalate.
What are the monitoring requirements for ofatumumab? So how do you monitor a patient on ofatumumab?
Now, so far, there was no, according to the pivotal trials, there were no red flags with ofatumumab. So probably just gonna monitor with the usual CBC and liver function test on a regular basis, like every 3 months. So far, I don't think there is any big issues. Probably the long-term data will tell us, but so far, no big concern from the safety data.
And so far, do we have data about dosing ofatumumab based on the CD19 or B-cell recovery, like we are doing with rituximab and ocrelizumab?
No, I don't think we do this, and there is no recommendation about doing this with a dose titration or delaying the treatment because of the CD19 or CD20. No, I don't think this is valid for ofatumumab.
So one of the attendees is asking, what is the difference between interferon beta 1A or 1B? And if there is any preference on starting an MS patient on any of the forms of interferon, or they just differ by the frequency of administration and the mode of administration?
I think the mode of administration and the frequency are the big differences. Now, we rarely use interferon. If you ask me when was the last time I used interferon, it's probably more than 5 years ago. Why? Because we have many options nowadays. Most patients would prefer orals or rather than injectables. Also because of the efficacy kind of standpoint, now we always go to moderate to high efficacy medication rather than a platform medication. So, but the difference in efficacy is probably negligible between all interferons. So we call them all platform therapy as interferon with no superiority between them.
A final question from me, how do you define treatment failure on alemtuzumab and cladribine? And if the patient fail those low frequency or once yearly administered medication, what would be the next option?
So you're talking, this is a good question, and it's a tricky question as well. When you are asking about immune reconstitution therapies.
Yes.
So for both of them, the minimum you would require is 2 courses. So if you administer 2 courses and you allow at least 1 year from the last course, and then if the patient has what we call suboptimal response, like either an increase in MRI lesion load, or a patient had a relapse, then probably we're going to call this is suboptimal response to the medication. I don't want to call failure. Failure is probably I would say is a tough word for the MS arena. All patients will fail a medication once in their time. If you follow patient for 20 years, 30 years, probably they're going to fail. Why? Because they're going to progress.
True.
Most patients going to progress with time. I
Yeah.
would say suboptimal response or disease breakthrough. I think these are the terms we used. If a patient has ongoing disease activity on the medication. For both immune reconstitution therapy, I think the best for me, I would give the 3rd course, either with alemtuzumab or cladribine, and follow the patient. If the patient fail again, or you want to call it suboptimal response again, here is the options, whether you change the actual mechanism of action of the medication you're using, or give a 4th dose. I would probably vote for changing the mechanism of action. So I wouldn't go with a 4th dose because we already have suboptimal response with 2 courses.
And a kind of similar question we just received from one of our attendees. So if a patient has a treatment failure or disease progression on B-cell therapy, on one of the B-cell depleting therapy, can we shift to another B-cell depleting therapy, or it's better to just go for a DMT with completely different mechanism of action?
This is a very good question. And I think this is a tough answer.
Yeah.
If you go with the approvals, the only approved medication for SPMS is Sipenomod, Mayzent. So if the patient already failing a B-cell depleting therapy, I think the option would be Mayzent at this time. Now, if a patient is progressing on other medication and you think whether you're going to go on B-cell depleting therapy or Sipenomod, this would be an option that you have to discuss with the patient, because B-cell depleting, ocrelizumab per se is only approved for PPMS, not being tested for SPMS. So I would usually go with the approved medication first. If they fail the approved medication, then I would go to off-label medication.
Another final question from Joelle. Joelle is saying hi to you, Dr. Raed, and she's asking you, is COVID-19 and vaccine future booster shots still playing a big role in our choice of DMT?
This is another good question. I think time will tell. At this stage, yes, it still plays a big role because we don't know whether we need a 4th booster or not, or a 2nd booster or a 4th shot. Not a big role in our decision, but it's a big role in timing the medication, especially when we talk about B-cell depleting therapy or, for example, alemtuzumab. We have to time the dosing of those who are already on them. Now, for those who are initiating treatment, probably it's not a big issue. We ask them to take the booster dose and then wait 2 to 4 weeks and start the medication. In the future, probably it will affect to a certain extent.
These were the questions. Thank you, Dr. Raed, for accepting our invitation. And with Dr. Raed amazing presentation, our first virtual clinics come to its end. Thank you for our esteemed speakers, Professor Celia and Dr. Raed. Thank you, Novartis, for sponsoring this activity. And the big thank you goes for you, our attendees, for staying with us until the end. I just want to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you miss any part of the webinar or would like to revisit the lecture, you can check our IVPN NeuroPsychiatry library, where we usually post all the recordings. Also, follow us on our social media platform and stay tuned for more virtual clinic in May and for our next activity, which will be on March 30 next week, and we'll discuss mental health in the era of COVID-19. Until we meet again, stay safe.